Welcome to our signature event for our Long COVID Research Policy and Economic Impact Series. My name is Emily Taylor. I'm the Vice President of Advocacy and Engagement for the Solve Long COVID Initiative and Solve M.E. I'll be your MC for today's conference. The Solve Long COVID Initiative is so proud to partner with the Global Interdependence Center as a continued part of this series going on for the whole course of 2022. As a reminder to everyone here, this event will feature speakers both in person and virtually through video conferencing, welcoming folks from all around the country with the miracles of modern technology. We're also happy to provide a patient rest area, which is located in the Manhattan Room on the 12th floor. This is a quiet space for any patients or anyone else who may need to step away for a flare-up or sensory overload. There's chairs and an outdoor patio and water available as well. You may notice that there are index cards on your table. We'll be using index cards for questions. So if you have a question during the panel, feel free to write it down and I'll collect it and pass it along to the speakers. Also, an important housekeeping item, restrooms are just out the door to the left. You'll see both of them there. And just so we are requiring masks at this event, but feel free to remove them while you're actively eating or drinking. I'd like to take this opportunity to thank all of our speakers today for joining us for all of your important work and exploring disabling long COVID. With that, please join me in welcoming Oved Amitay, the Executive Director of the Solve Long COVID Initiative, and Bill Kennedy, Board Chair for the Global Interdependence Center.
Good morning, everyone. It's a pleasure to be here and see you in person. And I was thinking about coming here and what is the risk and benefit of having an in-person event these days. And we all recognize that there is an increased risk by getting people together. But at the same time, I have to say that even the few minutes before the start of this event, already indicating to me that there's so much value in coming together, particularly as we bring people from different disciplines, different perspectives. And that's really the main focus of our event today. We started as an organization to be concerned about long COVID back in the summer of 2020. So very soon after the beginning of the COVID-19 global pandemic, our community, which has been affected by post-infection diseases previously, had the sensitivity and the concern that this may happen with COVID-19. And so already in the summer of 2020, we started to work with Congress, advocating for more resources to be directed to address that emerging concern. There was a House resolution, so a bill that was introduced by Representative Jamie Raskin that was called the Long Haulers Act, and it was also aimed at understanding populations with other post-infection diseases like myalgic encephalomyelitis already at that time. So we felt that there has to be a bridge between what we know and what we didn't know at the time and what was still emerging. And we felt that our organization was compelled to be this bridge because of what we know from the past and what we could see unfolding in front of us. I got to know the GIC through David Kotok. So about a year ago, when we started to see some of the numbers, or we started to be concerned about the number of people who are not getting back to where they were before they had the COVID-19 infection, I was very interested to see if we can get a sense of what the impact may be from an economical perspective. Obviously, there's a lot of personal suffering, but what do we know about the impact of that on the society as a whole? And there was really nothing that was written in the financial media or anything like that. And then I saw David Kotok's writing about that. And so we got in touch and we started to talk about the need for different communities, different disciplines, different perspectives to be aware of what is happening. And that's how we got together, and we felt that the two organizations, the GIC, and Bill, thank you for being a partner in this, and Solve M.E, could really serve, but really serve the community by bringing people together to have a greater awareness. And really break those silos, those ways that we tend to see a challenge from one perspective. So we have very different communities that or constituents that we had in the past, and this is really an opportunity to bridge that. So I'm delighted that we're able to do that. The topic of today is long COVID, which is in itself a very broad term, and I think that the speakers today will speak to that from different perspectives, and I think we're still using this term in a very, very broad sense, and it can encompass anything from people who are severely affected during their acute disease, they were hospitalized, and they are recovering from that, and that may take a long time. We're talking about people who had very mild symptoms initially, but they continue to struggle. So it's a very broad term. I think that we're going to use different definitions, and the speakers will probably help all of us understand what do they mean when they say long COVID. It's going to have a very different definition for a clinician. It's going to have a different definition for a clinical researcher. It's definitely going to have a different definition from a legal perspective if someone is looking for disability. So all those perspectives will be discussed today. And I hope that we can find the common denominator to understand that we need to address this challenge in a multifaceted way. I do want to just start today with reading the World Health Organization definition of what they define as post-COVID-19 condition, which the World Health Organization describes as a condition that occurs in individuals with a history of probable or confirmed SARS-CoV-2 infection. And the reason that the World Health Organization is using this at the beginning of the definition is that there are many people who do not have a confirmed PCR test that their disease really started with an acute infection. So I think we need to recognize that relying on on a single test like that to document whether someone is really having long COVID or not is problematic, and therefore the World Health Organization accepts that there is a probable history of a probable infection. So that's important to recognize. There are a lot of people who do not have this confirmation. And then they go on to say that it usually takes 3 months from the onset of COVID-19, and the symptoms can last for at least 2 months, and they cannot be explained by other diagnoses. So that's another important aspect of this definition. People who have now a lung injury or a kidney injury that is documented, well, that explains some of the symptoms. That is really not what World Health Organization defines as post-COVID. This is a different disease. And of course, that's the challenge. We don't have a different diagnosis. And so what is it? So the definition says that the common symptoms are fatigue. That's the number one symptom that people talk about, shortness of breath, and cognitive dysfunction, which a lot of people in real life describe as brain fog. And but there can also be other symptoms, and generally they have an impact on someone's everyday functioning. So that's an important aspect of long COVID. It does have a great impact on how people go on with their normal life. The symptoms may be new onset following the initial infection, or they could be a continuation of the acute infection, and the symptoms may also fluctuate or relapse over time. So that's another dimension that we're going to be talking about today. This is not a constant condition. It changes. So all of those are obviously challenges. We're going to talk about different aspects of that today. But before we start the program, I wanted really to thank all of the participants, the speakers, and also special thank you to our sponsors, our tech sponsors, Responsum Health, who enables us to have the event be streamed so that people with long COVID or other post-infection diseases can join us remotely. So we appreciate your support. And I also wanted to really thank the GIC for this partnership in having this event. I wish all of you a productive day. And Bill, if I may invite you to make your comments. Thank you very much.
Well, good morning and welcome to everyone here at the New York Athletic Club. And for all of you joining virtually, we welcome you as well. For 46 years, the Global Interdependence Center, which is also known as the GIC, has served as a global leader, influencing policies for the greater good. And this has come together through cooperative engagement with decision makers and diverse thought leaders, not just in the US, but around the world. Our mission at GIC is to explore globally interdependent issues that impact not just the world economies, but also our quality of life. And we can't think of a more important issue than long COVID and how that is going to impact economies and the quality of life going forward. Our organization has forged over nearly 5 decades very strong relationships with policymakers, central bankers, industry leaders, people in academia. And we do so to expand awareness and advance our shared interest and to promote social stewardship. And we always do this through a neutral, nonpartisan forum, very much like our event here today. Now, since the onset of the pandemic in 2020, the GIC has made a bit of a pivot where we have expanded our network to include scientists, epidemiologists, biologists, healthcare workers, and public health experts to help our members and the general public gain a better understanding of all of the interdependent impacts and influences that are coming from the pandemic and SARS-CoV-2. So on behalf of the GIC board, I want to thank you, Oved, and your staff for the partnership and collaboration on bringing this together. And I'd also like to thank our GIC board member, David Kotak, who Oved referenced. David will be moderating a panel later today, but through David and the Solve Long COVID initiative, we have received very generous financial support to host a year-long long COVID program series, of which today's program and today's conference is one part. So our objective today is to explore long COVID's impact from multiple perspectives, as Oved talked about. We're going to talk about scientific research, public health policy, the effect on insurers and pharmaceutical firms, the economic and labor market challenges, and probably the most important out of all of this is the human experience and how this is going to impact potentially the millions of people here in the US and around the world. So here's our promise for today's event. Today, you are going to learn something new that you have not known previously about long COVID. It will be the case that the examples that you hear, the techniques that are being discussed in research papers, some insights and ideas, maybe just one of these ideas today is going to make a breakthrough and help to improve the quality of life for someone that you know personally. So that's our promise. You're going to be exposed to many ideas by the end of the day. And our hope is that you'll take these back, this one idea back to your family, to your business, to your community, to your policymakers to try to make a difference. So let's begin. I want to invite to the stage Kate Mudie, Research Senior Manager with Solve M.E, who is going to present our 2 speakers, Dr. Bruce Patterson and Dr. Marjan Islam. Thank you.
For that introduction. Oops, take this off. So I will be introducing our speakers this morning for the first session. This is Drs. Marjan Islam and Dr. Bruce Patterson. Dr. Islam is assistant professor in pulmonary medicine and is the co-founder of Montefiore's clinical practice dedicated to treating long COVID haulers. And Dr. Patterson, previously the director of diagnostic virology at Stanford, is now the CEO at IncellDx, which is a biotechnology company. And we're going to be hearing about their fantastic, their fantastic experience with COVID and give us their insights into the research that they have conducted. Thank you.
I should go ahead
Yes.
first. Yes. And hope my PowerPoint will be loaded up. All right. Good morning, everybody. Thank you, Kate, for the introduction. I'm Dr. Islam. I run Montefiore's COVID Recovery Clinic. And my goal for today will be to discuss from a clinician's perspective, when a patient walks in who's recovering from COVID, what we see, how we evaluate them, how we think about, the symptoms that they're presenting to us with. And you look at our intro slide, you see that, I labeled it as after COVID-19 PASC, which stands for post-acute sequelae of the SARS-CoV-2 infection. And underneath, you see that I've labeled it under the umbrella as long COVID and other subtypes. And I'll explain, what that means, because it's very important to understand that everything that happens after COVID-19 can be put in the umbrella term as PASC, but underneath that, there's so many different types of phenotypes that will be determined based on the patient's course with the infection. Next slide, please. Oh, perfect. Thank you. So I think, we all agree with acute COVID-19. It's there's less debate on what that is. It's the symptoms of COVID-19 that present up to 4 weeks since the onset of illness. And, typically they present with either a viral URI or it could progress to something more severe like a viral pneumonia and even ARDS. And also, we've seen acute COVID manifest as strokes or thromboembolic disease. Post-COVID, though, is a broad range of symptoms that could be physical or mental that develop during or rather after COVID-19. And, the timelines are varied. The CDC and the NICE at the UK define it as greater than 4 weeks since acute COVID, whereas the WHO define it as 3 months since COVID and lasts for over 2 months. And it's not explained by an alternative diagnosis. And here we see, a number of different names for this post-COVID phase of illness. Long COVID, long haulers, post-acute COVID-19, PASC, chronic COVID, and the list goes on. The NIH, labeled this umbrella term PASC back in February of 2021. And we see, just based on this cartoon that, patients who have acute COVID, a lot of them do thankfully recover, but some have protracted symptoms where recovery is prolonged. And some patients even develop new onset of symptoms after apparent full recovery. Now, we've seen the wide range of symptoms that patients with PASC endorse. Most recently, I've heard up to 200 individual symptoms as being endorsed with patients who are recovering from COVID-19. And we see all the different organs and organ systems that's affected: neurologic, psychiatric, mental health, cardiovascular, pulmonary, GI, and some more other symptoms that are more multifaceted and range between the organs. And this is a flow chart that helps depict where a patient comes to us from. When a patient presents to me who had acute COVID, this is really the blueprint that I look at to kind of determine which patient am I looking at. And that can help try to tease out why they're feeling the symptoms that they feel and what could be the potential etiologies of those symptoms. So, following acute infection, we know a large number of patients are asymptomatic, but certainly some patients are symptomatic and they could be experiencing mild URI symptoms, headache, fever, body aches, for which typically we can have ambulatory management be enough, managed at home with supportive care. Now, certainly some patients can have severe viral pneumonias and severe infections that require hospitalizations. And within this category, patients can be severely ill or even critically ill. And, these manifestations of acute COVID, in the post-acute phase, these patients typically can have identifiable organ injury. What I mean by that is, these patients, through investigative diagnostic studies, we see that there is evidence of injury that could be explaining their symptoms: shortness of breath from a severe viral pneumonia, dyspnea, fatigue with a result of viral cardiomyopathy, a stroke causing neurologic symptoms. The list goes on, and we have diagnostics that can help explain these symptoms. On the left-hand side of the slide, though, you see that there are patients that have no identifiable organ injury. These are patients that present to us with complaints of shortness of breath, yet their chest X-ray, CAT scan, pulmonary function tests are all normal. Their cardiac enzymes, their cardiac markers are all normal. And this is really a group that I would label as long COVID. It's not to say that there is nothing wrong. There's certainly things that are wrong, but it's just that the routine tests that our clinicians are using to identify them, they most of the time return normal, and they're not able to explain the symptoms that our patients are presenting with. And on the far right-hand side, you see, a group of patients with PICS. PICS stands for post-intensive care syndrome. That's certainly a different entity in itself that results from recovery from severe critical illness from COVID-19. Now, there have been subtypes that have been proposed to kind of describe what this post-COVID syndrome is. And, we see here that there are 4 subtypes that the authors of this paper have described. Non-severe COVID with multi-organ injury, but that could be resultant from tissue injury across different organs and different organ systems. The pulmonary fibrosis sequelae is the patient that we see typically in the hospital and in the ICU with severe ARDS, acute respiratory distress syndrome from severe viral pneumonia. And then the last 2 is really where I think the focus of today's talk will be, which is myalgic encephalitis chronic fatigue syndrome and postural orthostatic tachycardia syndrome. These are 2 conditions that are poorly characterized, poorly defined, but present with similar features such as fatigue, unrefreshing sleep, cognitive impairment, orthostatic symptoms, tachycardia without hypotension. And the mechanism for why this happens is unclear, but we'll speak to that more today. But it seems to be due to dysfunction in the immune and nervous systems, particularly the autonomic nervous system. So let's talk about long COVID. Now, we've discussed the magnitude of the problem. It's difficult to, approximate the incidence of this condition, but reports range from 10 to 30% of patients who recover from acute COVID go on to develop this long COVID condition. And, this was accessed just a few weeks ago. The number is actually much higher now with daily cases, I think, over 80,000. And with total cases in the US of 80 million with a prevalence of 10 to 30%, you see that between 8 to 24 million patients could be experiencing long COVID just here in the US alone. In the UK, they provide us monthly reports on patients that are having symptoms. And here, 1.7 million people in April were experiencing self-reported long COVID symptoms as of March. And, these symptoms, if you look at the bottom left, they range pretty much around 20%, despite which variant was circulating at the time of endorsement of the symptoms. And the predominant symptoms are, again, similarly fatigue, shortness of breath, body aches, and anosmia. And the magnitude of impact, they say is limited impact in about 67% of those surveyed. and pretty severe in about 20%. So certainly pretty severe impact on patients' quality of life. So, when we're, as clinicians, when we're confronted with a condition that we don't know, the first thing we really do is try to characterize the epidemiology of the disease and see if that can provide us with insights into the pathogenesis of why this disease is happening. So I'll briefly review some studies that can help lay out the epidemiology. This was a study of 100 patients from a multidisciplinary clinic in the Mayo Clinic. And we see that patients that presented here with long COVID symptoms overall were fairly young. Age was about 40, 45 years old, predominantly female, 68%. And the time from onset to presentation was several months, 90 days on average. And we see that the majority of patients were not hospitalized. And the symptoms that were endorsed were fatigue, respiratory complaints, neurologic complaints, cognitive impairment. And we'll see that, this spectrum is a theme here and fairly replicable despite what study you look at. This was a study of patients in an international cohort in over 30 countries across 7 months. And here we see a very similar profile where in the survey of over 3,000 patients, 80% were women, 20% men. Symptoms were predominated in patients who were fairly young. And again, patients were largely not hospitalized. And we see that, certainly the prevalence of symptoms is pretty dramatic, over 30% prevalence in a number of different conditions, including fatigue, post-exertional malaise, brain fog, and the cognitive impairment is pretty astounding. And certainly, this study has selection bias in that patients that are participating in a survey like this are more likely to be experiencing symptoms. But still, we see that patients who are endorsing symptoms, the magnitude of the debility is pretty significant. When they track these patients over time across these 7 months, we see that, the severity of symptoms, the patients that felt that the symptoms that were most severe over time did decline. While symptoms that they felt were moderately debilitating persisted. And when they looked at, whether patients recovered or not, we see that a certain number of patients do recover within 90 days, but a significant number, there's no abatement in the presence of symptoms despite the end of the study at 7 months. This study also tried to cluster symptoms on different trajectories of whether these symptoms are abating or whether they're persisting or even increasing. And, cluster 1 symptoms, the viral URI and GI symptoms seem to decrease over time, whereas symptoms that were cardiac, pulmonary, or neuropsychiatric seem to plateau. And symptoms that included, again, neuropsychiatric or dermatologic symptoms, they seem to increase over time. And you just see the list of symptoms that these patients endorsed are pretty extensive. This was a study that looked at patients, again, to see how many patients, would recover over time. And this study used a 53 symptom validated tool. And here again, not to belabor the point, but the patients are, again, predominantly female, predominantly young, predominantly non-hospitalized. And at the end of this study, in about 360 days, we see that, this graph denotes patients that had symptom resolution. So at the end of 1 year, about, less than 30% of patients had complete resolution of symptoms, with the predominantly patients continue to have symptoms despite the end of the 1 year mark. And when they tracked, again, clusters of symptoms, they found that, certain symptoms like cough and loss of taste or smell did decrease, whereas symptoms related to fatigue or paresthesia seem to increase or plateau over time. And on the right-hand side, we see that the impact of the patient's lives, the severity of impact takes a U curve, meaning in the beginning, as symptoms slightly beginning to improve, the impact on their lives decrease. But then towards the 1 year point, we see that, the severity of impact starts to climb up again. And, the authors believe that this is occurring because patients are beginning to realize that this condition is a chronic condition. 1 year out, they're still experiencing symptoms, and it's beginning to cause more stress, more depression, more anxiety, and overall increased impact in life. This is probably the longest longitudinal study published. This was just published a few days ago in patients who were actually hospitalized for viral pneumonia. But again, 2 years out, the patients, the authors compared the patients that were hospitalized with controls that were matched with by age, sex, and comorbidities, and they found that across really all domains, patients who had COVID 2 years ago endorsed more symptoms compared to age and sex-matched controls, even at the 2-year point. And we just see the symptoms are pretty wide-ranging, fatigue and sleep difficulties being the most common. And these patients likely have recovered from their viral pneumonias, but still have symptoms that persist. And if you remember from the flowchart that I reviewed, patients can have severe illness, but then still have long COVID symptoms that are not attributed to direct organ injury. In this study, the authors had a subset of patients that they deemed as long COVID symptoms, and compared to patients who were survivors of severe pneumonia that didn't endorse these long COVID symptoms, the long haulers had lower quality of life, worse exercise tolerance, increased mental health symptoms, and more healthcare utilization post-hospital discharge. Focusing briefly on the neuropsychiatric components, this was a large meta-analysis of almost 10,000 patients. And interestingly here, you see that compared to patients who were not hospitalized to those that were hospitalized, there was significantly higher prevalence of neurocognitive symptoms in patients who were hospitalized. Here we see in a odds ratio of risk, they found that patients who were hospitalized for COVID actually had over 50% reduction in neuropsychiatric symptoms. Again, this doesn't suggest that being hospitalized is somehow protective, but it does speak to the underlying pathobiology of who this disease affects. And if you tend to have more severe disease, these patients tend to be older and tend to be male, they have a completely different experience with this virus than patients who are not severely affected with respect to degree of viral pneumonia and their own epidemiology of being younger patients who tend to be women. On the left-hand side here, they tracked the symptom progression between 3 months and longer than 3 months. And interestingly here, you see that the severity of neurocognitive symptoms actually seem to increase at 6 months or more compared to at 3 months. So what does this suggest? This suggests that for some reason, the neurocognitive symptoms are worsening the longer out you are from the initial acute COVID-19 infection. And that's a really troubling finding here. And how can we explain it? It's going to be difficult to explain, but it could be due to something that's not related directly to the virus itself. It could be due to autoimmune features, autoimmune conditions, neuroinflammation that propagate, farther into, the long COVID timeline than during acute infection. There was a recent study published this year from the UK Biobank that looked at MRIs of about 800 patients that, the study was really well designed in that they had patients that they had MRIs prior to COVID and MRIs of the brain post-COVID, and they were able to track changes that occur in the brain after COVID-19. And they found that, there were significant changes in gray matter thickness. There were significant changes in the overall size of the brain in different areas of inflammation that was found in the brain compared to patients that didn't have COVID-19. They also found in the study that there was a cognitive decline as well in patients that had COVID-19. Now, so what we're seeing here is that there are evidence of organ injury and brain MRI in patients who are survivors of COVID-19. But with that said, there have been additional studies where there are cognitive dysfunction in long haulers where their brain MRIs are completely normal. So again, this suggests that, patients can be experiencing symptoms where one cohort we have direct evidence of organ injury, and another cohort where, again, the routine tests that we do come back normal, and yet we don't have a great explanation as to why the symptoms are present. This is just a slide that, compares, protracted symptoms in COVID versus influenza, and, compared to post-COVID, compared to post-influenza, patients who've had recovered from COVID have increased in symptoms across multiple domains. Post-viral syndromes are common, but COVID seems to be particularly nefarious in its impact in these long COVID, in the post-viral symptom magnitude. This was a study that came out not too long ago that tried to identify risk factors for PASC. And it was a multi-omics longitudinal study. And what they found was 4 significant risk factors that could predict whether a patient would have long hauler syndrome. And the 4 were evidence of viremia, meaning the higher viral load there was, that seems to increase the risk for long COVID, certain comorbidities, particularly diabetes, presence of autoantibodies that were subclinical in nature, and also reactivation of latent viruses, particularly EBV. Now, is this EBV causing a condition called ME/CFS, or is this long COVID where a latent virus reactivation is playing some role? That's going to be something that future studies will determine, but these were the 4 factors that they found. They also found that the presence of subclinical autoantibodies negatively correlated with presence of anti-SARS-CoV-2 antibodies. So what does that mean? Could that mean that, if your body is generating these autoantibodies, it's, a misdirected autoimmune response where autoantibodies are developing, yet the antibodies you need to clear the virus is not forming. So it's a dysregulated response to the virus from a patient's own immune system. Now, let's talk about a few studies with respect to POTS, postural orthostatic tachycardia syndrome. This is something that we've seen in patients with long COVID. Again, this is a multi-system disorder with a preponderance of young women that seem to be affected. Several mechanisms seem to be at play: hypovolemia, autonomic dysfunction, maybe autoimmunity. How do we diagnose this condition? It's where patients have symptoms of orthostatic intolerance with or without systemic symptoms. And we see that patients, when they are upright from a supine position, their heart rate goes up by about 30 beats per minute within 10 minutes of standing without associated hypotension. And this was a study where they looked at autonomic dysfunction in patients who were recovering from COVID. In about 27 patients with PASC with autonomic dysfunction, they found that 60% were female, predominantly young in the age of 30. 63 had abnormalities on autonomic function testing ranging from symptomatic orthostatic tachycardia to postural orthostatic tachycardia syndrome. And here we just see a graph of one patient where when moving from a supine position to standing up, in the green line, we see a sudden rise in heart rate. And in the red line, a slight drop in blood pressure. And on the right-hand side, these patients also had areas of thermodysregulation with sweating in different parts of the body, suggesting that this patient had some kind of sensory autonomic ganglionopathy. How do we look for POTS in the clinic? There is a test called the NASA lean test. And it's essentially a quick study that we can do where we keep patients supine for 10 minutes, and then upon having them stand with them leaning against a wall, we can measure their heart rate and their blood pressure. And essentially, this was a study where they did this in ME/CFS patients, and they found that patients who had prolonged ME/CFS, meaning symptoms that lasted greater than 10 years, they had a significantly higher heart rate with standing and an abnormally narrow pulse pressure. And a pulse pressure is just a measure that's the difference between your systolic and diastolic pressure, and a narrow pulse pressure suggests inadequate ventricular filling, return of venous blood flow to the heart, and low venous return pressures. And why is this important? These measures are determined by an intact autonomic nervous system. When we stand, the reason we don't get lightheaded is because our autonomic nervous system counteracts the effects of gravity by increasing our vascular tone, slightly increasing our heart rate. But in patients with dysautonomia, these symptoms seem to be much more exaggerated, suggesting that there is some kind of autonomic dysfunction. This was a study looking at CAT scans of patients who had recovered from COVID-19. And I just want to highlight the ambulatory patient here, where in 100 patients where they did expiratory CT scans, 25% of patients that were ambulatory managed, meaning they didn't have viral pneumonia, they did have air trapping. And air trapping on a CAT scan is demonstrated by, on the CAT scan, we see that there are areas of gray and areas of black. Areas of black is just regions where air is trapped during exhalation. And this is something that we see commonly in patients with COPD, asthma, bronchiectasis, different obstructive lung diseases. And what is notable here is in patients who didn't have viral pneumonia, a significant portion had air trapping compared to controls. And this was not something that was detected on routine spirometry, but was shown in pulmonary function testing. And why is this important? Well, this could be an indication that we do have some evidence of organ injury in these patients that are complaining of shortness of breath. And we know from other viral conditions that they can affect the small airways, particularly in a condition called constrictive bronchiolitis, where the small airways thicken and hypertrophy, resulting in limitation in expiratory airflow, which could be, something that's causing patients with long haulers their sensation of dyspnea. This was a really interesting study that looked at, how am I doing, 5 minutes? So this is a really interesting study where they did invasive cardiopulmonary exercise testing, and 10 healthy patients that had PASC. None of these patients had pre-existing cardiopulmonary disease. All of them had very mild COVID-19, meaning they were all managed in the ambulatory setting. And essentially what they found, one other important note is these tests were done 11 months on average since acute COVID. What they found was there was a significant reduction in the peak exercise capacity in the PASC group. And they measured this by a measure called VO2 max, which is a metabolic measurement that approximates peak exercise capacity in patients. And this was determined due to impairment in systemic oxygen extraction. CPETs are done when a patient presents to us and we're not quite sure why they're limited in their exercise capacity, why they're fatigued, why are they feeling shortness of breath. And we use it to see if there's a primary cardiac limitation, primary pulmonary limitation, or is it due to something like deconditioning. In this group of patients that had PASC, they found that there was no cardiac limitation, no pulmonary limitation, and the limitation seemed to occur primarily due to a reduction in the body's ability to extract oxygen from a peripheral circulatory area. And the suspected pathogenesis here was due to microcirculatory dysfunction due to small fiber or autonomic neuropathy. Meaning, we have our nervous system that regulates vascular tone, ability for oxygen to be extracted, and the authors ruling out cardiac and pulmonary limitation felt that this could be due to disease in the small peripheral nerves that innervate the musculature. So what exactly is small fiber neuropathy? This is a condition that occurs in numerous different conditions, diabetes, autoimmune conditions, and the treatment really is based on what the underlying reason for the small fiber neuropathy is. This was a study looking at peripheral neuropathy in patients with long COVID. In 17 patients, all of whom had mild disease. Again, the epidemiology, younger patients who are women. And 10 of these patients were diagnosed with small fiber neuropathy by biopsy. And, this again is some evidence that this could be one of the pathologic mechanisms for the autonomic dysfunction we see in these patients. Potential treatments for small fiber neuropathy could be corticosteroids or IVIG, but this is very much in a speculatory phase. There's also been some talk on whether mast cell deactivation could be a potential mechanism for long COVID. Mast cells harbor histamines and specific cytokines that are activated in SARS-CoV-2. And there's been some studies looking at whether antihistamines, H2 blockers can attenuate the hyperinflammation that's seen in acute COVID and as well as in the post-acute phase. There's a condition called mast cell activation syndrome, which is a chronic multisystem disorder with inflammatory symptoms that overlap with long COVID. And there's some belief that whether long COVID and mast cell activation share some pathophysiologic shared underpinnings. Mast cell activation syndrome, has a lot of different symptoms that overlap with long COVID. And this was just a study looking at patients that had COVID and compared them to patients that had mast cell activation syndrome, and compared to pre-COVID endorsement of these symptoms following COVID, a cohort of about, I believe it was 30 patients or so. There was striking overlap between mast cell activation symptoms and patients with actual mast cell activation syndrome. This was a study where they looked at patients that had T cell abnormalities as well as a response to antihistamines. Again, it was just an observational cohort study where they compared patients that had long COVID and compared a group that received antihistamines compared to those that didn't. This wasn't a randomized control trial. It was just an observational cohort study. And they did find significant reductions in long COVID symptoms that took antihistamines compared to those that didn't. What can we make of it? Probably not a whole lot, but it is interesting and could speak to the pathogenesis. Again, we've mentioned ME/CFS as a potential post-viral condition that is what long COVID is, or a subvariant of what long COVID is. There have been numerous studies that suggest that there's some overlap in these two conditions. I'm running short on time, but ME/CFS is diagnosed by post-exertional malaise, orthostatic intolerance, unrelenting symptoms that are not improved following sleep, as well as cognitive impairment and orthostatic intolerance. A lot of these, as we've demonstrated, seem to mimic long COVID symptoms. So is long COVID simply ME/CFS that results following SARS-CoV-2 infection? When a patient presents to me, the differential diagnosis is quite wide. We look at a lot of different things that could be occurring. We try to identify potential comorbidities. Certainly, if we treat, say, sleep apnea, that's untreated sleep apnea, then that can mitigate the severity of fatigue that these patients can experience, without truly addressing the underlying condition, because we don't quite know that yet. We can mitigate some of the symptom severity by treating comorbidities. What is the pathophysiology? Is it persistent viral reservoirs for which antiviral therapies could be beneficial? Is it autoimmunity for which immunosuppressant medications could be beneficial? Is it mast cell activation for which antihistamines could be beneficial? Is it reactivation of latent viruses for which specific antiviral therapies are important? Could it be small fiber neuropathy from an autoimmune mechanism for which IVIG could be beneficial? We don't know. The pathophysiology really has to be better delineated before we can really start therapies for this condition. There is a clinician coalition in the US that manages ME/CFS, and really, most of the therapies that we do are behavioral modifications such as pacing, management for orthostatic intolerance with fluid loading, salt loading, and there are some medications you see here on the left-hand side that may mitigate some of the symptoms, but again, these are just mitigating symptoms rather than addressing the underlying pathophysiology of why these symptoms are occurring. I'll stop there, and thank you for your attention.
Thank you very much, Dr. Islam. Before we go forward with Dr. Patterson's talk, I would like to let you know that we will be taking questions at the end. And so for those who are in person, there are cards on your table with pens. And if you can write your questions on the card so we can minimize passing around a mic. And then for those online, if you could just type them in the chat box. So thank you. And now we'll have Dr. Patterson with his talk.
Thank you. It's really a pleasure to be here and talk about this very interesting and complicated topic. What's really appropriate is that Solve Long COVID came out of Solve ME/CFS, which I'll talk about a lot during the course of my talk. When we look at the pandemic and go back and look at the beginnings, and I was in China in February of 2020, and in Shanghai, and I actually was summoned back to the United States and told not to go to a customer in Wuhan. And one of the companies I was visiting in Shanghai showed me some data on these patients who had this immune virus. And what really struck me was the engagement of the innate immune system, which is our first arm of our immune system that basically looks at infections that we haven't seen before. And it's very macrophage driven, lots of pro-inflammatory cytokines and other mechanisms at play. And then eventually we develop adaptive immunity. But, along the lines of fighting off these infections, we also encounter things what we call damaging immunity. And this was described by Joe Belanti, who was a collaborator of mine. And again, it's the liberation of cytokines such as interleukin-6 and TNF alpha that cause significant tissue damage and significant symptoms. As we go through the course of my talk, one of the things we really found out is what cytokines, what inflammatory markers are causing what symptoms. And I think that's going to be the hallmark of what I'm going to talk about today and the treatments that we've been using. Oops. Did it freeze? Yeah, okay, so as been discussed, PASC may affect up to 30% of all individuals who have been infected by SARS-CoV-2. And it represents a real healthcare and economic emergency that has to be addressed on every level. And our data that we showed in 2021 is that PASC is really driven by vascular inflammation, which is caused by the persistence of the S1 protein in white blood cells called monocytes, months and now years after infection. We've shown that in a number of papers that we've published over the last 2 years since we started looking at long COVID. We now have over 24,000 patients in our program around the globe. And really the focus of our treatment has been the disruption of these mechanisms with what I call CCR5 antagonists, which I'll talk about in a moment, and statins. And this has really resulted in profound improvement in greater than 80% of the patients that we've treated. But most importantly, as I'll describe, is the proper classification of patients, because of what we've heard is that many of the symptoms overlap with other conditions. And those conditions are post-vaccination individuals with long haulers symptoms, post-Lyme, fibromyalgia, ME, CFS, and there may be others. And we developed a classification scheme to tell the difference between all of those conditions, because there's subtle differences in the way we treat these patients. Next slide. Next slide. Are we frozen again? Okay, so this is a figure that came out of our first paper where we described the most prevalent symptoms in post-COVID or in long COVID: fatigue, brain fog, post-exertional malaise, neuropathy, et cetera. And in red, you see some of the major symptoms in ME/CFS, which overlap significantly with what we see in long COVID. What you haven't seen is this figure from our new paper, which shows in individuals who have been vaccinated, who have symptoms longer than 3 months that are PASC-like, they too have the same symptoms: neuropathy, fatigue, post-exertional malaise, brain fog. And it's quite similar amongst all of the vaccines. So we don't see any uniqueness in what symptoms are caused by which vaccine. But the fact is, we have many patients presenting with what they think is long COVID, yet have never had COVID, but were vaccinated. And the symptoms occurred immediately after vaccination. We think that prevalence is relatively low relative to the prevalence of long COVID and what we think is exacerbation of ME/CFS, which you see in this slide. It's quite extensive. And that's why we think this is a key healthcare and economic emergency throughout the world. Now, what did we learn during acute COVID? Well, we started doing clinical trials for acute COVID for a variety of different drugs, including CCR5 antagonists, in February of 2020. And what we found, which you see in panel B, is a profound decrease in the percent and absolute number of CD8 T cells. As you know, CD4 T cells and CD8 T cells combine to form the adaptive immune response against virally infected cells and tumors. And we found levels of CD8 T cells that were similar to the levels of CD4 T cells in HIV and AIDS. So there's a profound immunosuppression during acute COVID, which allows latent viral viruses such as the herpes family viruses, HSV, EBV, CMV, HHV6, varicella, and others, to become reactivated. So we saw the paper in the previous talk about what indicators suggest that you'll become a long hauler. My response to that paper is you just showed what symptoms are actually going to predict who is actually going to have an exacerbation of ME/CFS. Okay. That's why it's critical to nail down the classification of these different syndromes that are identical, because in pure PASC, you have to rule out any of these chronic herpes family viruses because of the immunosuppression associated with acute COVID. And that goes for Lyme as well. We're seeing reactivation or exacerbation of Borrelia, Bartonella, Babesia replication, which is exacerbating post-Lyme symptoms, which are fatigue, post-exertional malaise, brain fog, joint and muscle aches. So all the same symptoms that you see in long COVID. The other important aspect is you have to know where you are in the continuum of long COVID. We published this paper last year showing that you can still have viral replication even 3 months after initial infection. And 3 months happens to be the cutoff for long COVID. And so what we see is this evolution in long COVID where early on, maybe 3, 4, 5 months, vaccines, monoclonal antibodies, antivirals may be effective in that particular patient. But I'm telling you, at 8 months, 12 months, 15 months, now 24 months, there's no viral replication. There's persistent protein and there's fragmentation of the RNA, which we published in January, and which was actually confirmed in this article on the gut, I think in the last week or two, where they called it viral ghosts, which is persistence of protein and only fragmented RNA. Now, we developed a system after looking at over 150 different biomarkers in acute COVID that could identify who has long COVID and some of these other immunologic conditions using a variety of different algorithms. Now, we used AI and machine learning in these individuals that we found after various trials in acute COVID who were better. They got out of the hospital, they didn't die, but at 60 and 90 days, their immune systems were nowhere near normal. That's when we discovered in the summer of 2020 that these individuals who were having symptoms had something real. And I can't tell you, when we came out with this data, they were being gaslit by physicians saying, oh, you have PTSD after acute COVID. Nobody was believing them. And we came out with our first paper in Frontiers of Immunology and showed this very distinct immune profile in these individuals with symptoms at 90 days post-infection, that a profile that was very, very different than acute COVID. Now this kit has been launched in the United States, in Europe, in the UK, and we're about to have regulatory approval where it'll be the first diagnostic for long COVID. And as I'll show you, we've adapted the elements of this kit in a variety of different algorithms to encompass classifying ME/CFS, fibromyalgia, post-Lyme, et cetera. What was really interesting is we went to great extent to validate in many different ways this cytokine profile assay. The laboratories validated it technically so that they could launch it under CLIA and CAP regulations. We validated it biologically by looking at interrelationships in cytokines in all these chronic inflammatory diseases. For instance, you see these boxes around these dark squares. Well, IL-13 and IL-4 is that top red box. They're both type 2 inflammatory cytokines, and they should be associated. So the darker the color, the closer the association between these individual cytokines. And again, interferon gamma produces or drives interleukin 10 expression. Another example of the performance and the biological relevance of this combination of cytokines and chemokines that we derived using AI and machine learning for long COVID. In our first paper, we showed using two algorithms, on the horizontal axis, the long hauler index, and on the vertical axis, the severity index for acute COVID. And we showed in yellow that long haulers had a very distinct grouping relative to acute COVID, which would be to the left of the dashed line if I included those in here. And then of course you see post-vaccination long haulers in red and ME/CFS in blue. So there are some similarities between long COVID, ME/CFS, and post-vaccination long haulers, but there are differences that allow us to come up with a unique classification scheme. So we put all this data from all these conditions in what's called a confusion matrix, which is basically a machine learning tool that is more or less related to the accuracy of our ability to define these conditions with those 14 cytokines and chemokines. The lighter the color, the better the accuracy. And of course, we have great accuracy in defining pure PASC. We also have great accuracy in acute and severe and mild to moderate acute COVID, and also in defining ME/CFS. Where there's confusion, at least from a statistical standpoint, is the definitions of Lyme and post-vaccination long haulers. And the reason being, which I'll show you in a moment, is that they share some commonality in terms of their cytokine expression that are very different from these other conditions. That's what's seen here in this cytokine nodal classification that we just submitted for publication. It's out in preprint. It's a very difficult graph to look at because it's so small, but it shows the beautiful separation of these conditions based on our classification scheme. So in purple, we have ME/CFS to the far right. In green, we have pure PASC or pure long COVID. In blue, we have post-vaccination long haulers. And in pink, we have Lyme. And in orange to the far left, we have acute COVID, all nicely separated by their cytokine profile. Now that's seen better in this schematic, which you have major cytokine hubs, and then each of the rectangles represents cytokine nodes. So for instance, with ME/CFS, it's defined by low CCL5, high TNF alpha, high interferon gamma. With PASC, which you see in green, it's defined by interleukin 2, interleukin 4, and interferon gamma. What's so satisfying about this schematic is we used a totally different algorithm and classification system. And for pure PASC, IL-2 and interferon gamma popped up again. And those are the numerator of our long hauler index, which we use to monitor treatment to show that patients are actually getting better on therapy. And then if you go further to the left, you see a cytokine node with IL-13. Well, IL-13, when we see that elevated, it can be either Lyme or post-vaccination long haulers. And of course, we can separate those two by history. But with the nodal system, we can also separate it because post-vaccination long haulers have higher elevations of interleukin 4 than Lyme patients do, okay? And then Lyme can also come off of the IL-8 node, which you see to the further left. What's really satisfying about this computer modeling, because the computer modeling has no information from prior literature, interleukin 8 expression is associated with Lyme arthritis, and IL-13 expression is associated with neurolyme, okay? It's amazing how AI can come about these answers that agree with publications that were written 10 or 20 years ago. Now, what's causing all this? Well, we published a paper in January in Frontiers in Immunology, where we found S1 protein in monocytes up to 15 months post-infection. As you can see in the blue square, there's actually non-classical monocytes carrying the S1 protein. And in red, in the box, you can see there's actually intermediate monocytes carrying the S1 protein in long COVID. And if you look at that, it's statistically significant compared to healthy controls, of course, and patients with severe acute COVID, both in the intermediate monocytes, which is in the middle graph, and in the non-classical monocytes on the far right. We sorted those cells. So we isolated those cells from long haulers. We broke open the cells, we took the proteins, and we ran them with a highly specific assay called mass spectrometry. And you see in the blue lines, a single spike, which represents the S1 protein in these cells, which we confirmed with mass spec. We also isolated the RNA from these cells in long COVID at between 8 and 15 months, and found by whole genome sequencing that the RNA was fragmented. And in some cases, less than 50% of the viral genome was represented in these cells, meaning there's no replication competent virus, okay? That's something that's been discussed ad nauseum in the literature. What's fascinating is that in post-vaccination individuals with long hauler symptoms, they too have the S1 protein in the same cells in their periphery. What's different is we also found S2 protein, excuse me, and some mutations in S1, which we don't know what the significance of those are quite yet. This is an unfortunate experiment that proves our hypothesis that long haul COVID is being driven by the S1 persistence in monocytes, because here we have essentially a unfortunate experiment where you're basically just giving patients S1 protein in the absence of replicating virus. They have the same symptoms, they have the same pathology, which is persistence of the S1 protein in monocytes, and they have the same vascular inflammation that we see in long COVID. We confirmed this in 3 patients who donated tissue, 3 long haulers who donated tissue, where we did sequencing, whole viral genome sequencing of the virus, because we've heard reports about, oh, there's RNA in this tissue, RNA in that tissue. Well, the fact is there is RNA. We showed that out to 15 months in monocytes. We're now showing it out to 12 months in tissues, but look at the coverage. It's less than 6% of the whole genome of the virus. It's impossible for that virus to be replication competent, okay? You can't build a building with 5% of the bricks, okay? And it's because they're using techniques like PCR and in situ hybridization techniques that can detect fragments of RNA. I'm not debating that there's RNA in tissues. I'm debating that in long COVID, in the later months, that it's actually replication competent. We already showed at 3 to 4 months it is. So we have to think about, when we're talking, we have to say, this is pure PASC or pure long COVID. And oh, by the way, there's a continuum that exists where that's evolving. And we have to take that into account as we think about treatments and we think about clinical trials, okay? Classify it appropriately, or else you're gonna have a clinical trial with ME/CFS, post-Lyme, long COVID, post-vax, fibromyalgia, and we all know how that'll turn out, okay? This is critical as we evaluate therapies, and we're about to start our randomized clinical trials in a few months. Why is this happening? Well, non-classical monocytes bind to blood vessel cells called endothelial cells, which line the blood vessels. And they bind through this protein called fractalkine. And that causes inflammation of the blood vessels. Well, what does that do? That produces type 1 cytokines, interleukin 2, interferon gamma. So a paper from 2004, interleukin 2, interferon gamma are the numerator of the long hauler index. Okay, RAI was unaware of a paper from 2004 about what vascular inflammation causes. Okay, here's another example. Monocytes bind to the vascular endothelium through fractalkine. What does that cause? It causes angiogenesis by producing VEGF. VEGF is a marker that we see across the board in long COVID, post-Lyme, ME/CFS. What does it do? Well, it actually makes blood vessels grow, but most importantly, it causes peripheral neuropathy, okay? And as I'll show you in our clinical trial, when we decreased VEGF, neuropathy went away, dysautonomia went away, okay? What else does this binding do? It causes vasodilatation. Vasodilatation causes this head fullness. I said on Dr. Drew's show one time, this is the universal sign of long COVID. Patients come in and say, you know what? It's my head. It's my head. It feels like it's going to explode, right? And I say, I get it. because there's vasodilatation causes this head fullness. Vasodilatation causes headaches, migraines, brain fog, tinnitus. Okay. You know what else vasodilatation does? Causes cold and hot heat insensitivity, which almost every long COVID patient has. Okay. So, and you know what else it does? Vasodilatation drops your blood pressure. And what does your body do in response to low blood pressure? Increases your heart rate. There's your POTS. I'm telling you, when you relieve the inflammation in this mechanism, all that stuff goes away. But I want to get to treatment in my last few minutes. We included soluble CD40 ligand in our panel 2 years ago because it's the first sign of a potential clotting cascade. And so we were well aware that clotting and the so-called microclots is a possibility. And we know that when we bring down soluble CD40 ligand with statins, we remove the possibility of clots. We must remove the cause. Going and getting your clots sucked out every few months is not the answer. Okay. So now what? Treatment. We used our criteria to define pure PASC. We did a trial with 20 patients of pure PASC where we gave them Maraviroc, a CCR5 antagonist, which keeps these inflammatory cells from migrating all over the body, and statins, which keeps them from binding to the blood vessels. Okay. You know what we found? We used 5 symptom scores used in clinical trials and recommended by the FDA. This is cardiac function. We saw a statistically significant difference after 6 to 12 weeks in therapy. And our statisticians related that to biomarkers so that we had a correlate. We knew if we brought these markers down, we'd have an improvement in symptoms. Rankin, which is neurologic disability, statistically significant decrease after 6 to 12 weeks, related to soluble CD40 ligand and VEGF, which were statistically significant. Compass 31, dysautonomia score, highly significant decrease after 6 to 12 months of therapy. It's related to decreased soluble CD40 ligand, VEGF, GM-CSF, okay? Dyspnea, or shortness of breath, statistically significant improvement over 6 to 12 weeks related to those cytokines on the right. Most importantly, fatigue across the board in all of these conditions, ME/CFS, post-Lyme, long COVID, the fatigue score went down statistically significantly. And look at the p-values on IL-2 and TNF alpha and the correlations. We know if somebody has elevated TNF alpha and IL-2, which they do because IL-2 is part of the long hauler index, we bring those down, we're going to get improvements in fatigue. So what we've been able to do is relate symptoms to cytokines and then use drugs to target the appropriate cytokines. That's cytokine hub directed therapeutics, which has been proposed for autoimmune diseases as well. With that, I'd like to thank my group. We have worked tirelessly for 2 years now. Like I said, we have 24,000 patients. We have 8,000 patients that we've treated with these 2 drugs, which are already approved. And we'll be taking these through a phase 4 or an EUA clinical trial in the coming months to see if we can get the first approval on a long hauler drug combination. And we are 1 or 2 weeks away, May 26th, of having the first regulatory approved diagnostic test for long COVID to help us monitor response to therapy. And with that, I appreciate your time and thank you.
Thank you both for that. I think we'll turn on the microphones. Oh, okay. Thank you. So before we get to the questions from the audience, I just would like to ask a couple of questions myself. So one of the first things that you mentioned, Dr. Islam, I noticed is that really long COVID is a syndrome that is diagnosed by elimination so far. And this sounds familiar in the ME world as well. And I wondered if you could talk about perhaps how we could use our knowledge of ME and the diagnosis for the field of long COVID.
Well, you're right in that it has thus far been, a diagnosis of exclusion. Certainly, with COVID, there's an antecedent viral infection. So that seems to be pretty important for ME/CFS in that there has to be a time where you can clearly delineate, I was fine until that time. And then there was an event that following I had development of symptoms. With respect to elimination of comorbidities, it's hard to say, if symptoms are exacerbated from long COVID, or it's actually not long COVID, but a comorbidity here and there. Our approach has been really to look at symptoms and identify specific organs that the dysfunction in these organs could manifest in those symptoms and eliminate, any abnormality in those organs. Once those are eliminated, and we can't identify a specific reason as to why a patient's having symptoms, we presumptively label them as having long COVID. But like you said, there's no diagnostic studies that we have on our routine labs that can help confirm that. But, Dr. Patterson's suggesting that there are certain chemokines and cytokines that may delineate a specific profile. So I'm very curious to see, you said May 26th.
Well, no, they're offered at 2 major reference laboratories in the United States. You can order them right now. And we get CE-IVD approval in Europe in May 26th. So.
That's excellent. And Dr. Patterson, you mentioned that you can use the test up to 15 months. Is that right, following infection? Or is there a timeline in which it works best to be able to distinguish and identify these long haulers?
But we use it throughout the course, from 3 months on, because clearly the immune system's evolving and it's changed over to a more long hauler immune system at 3 months. But as I mentioned, could still be viral replication. How do we know that? Interleukin-6, because we don't see interleukin-6 in long COVID. And then, for instance, we can use these cytokine profiles to say, where are you in this continuum? And then this winter, we had a lot of our long COVID patients who were almost completely better, and they get Omicron, right? And they don't always know it, but they come in and they have an interleukin-6 of 50 or 100 when it's supposed to be less than 1, right? So immediately say, okay, you had Omicron, didn't you? Oh yeah, about 2 weeks ago I had such and such. So that's what we have to deal with. And as far as other conditions, what we were finding is everybody would come with long COVID because now the symptoms are all over the media. They would come in, and then you do a telemedicine, you talk to them, you say, okay, when did you have COVID, et cetera, you go through a history. And they said, then you'll get, oh, by the way, I had bad EBV 3 years ago. Or, oh, by the way, I had a tick bite in 2012 and I was treated for a year with a PICC line for Lyme disease. So, again, and in the last 2 weeks, since we came up with the classification scheme, I saw 5 patients who had elevated interleukin-13, and they didn't say anything about Lyme. And I said, by any chance, have you had Lyme? Oh, yes, in 2008. That was a long time ago. Like, well, you have post-treatment Lyme disease, probably on top of the fact that you may also have long COVID, or maybe it's just an exacerbation of your PTLD. So it's so critical to have precision medicine. I've said this numerous times. You know what? There has never been a more complicated disease in my almost 25-year career. in medicine, and to not use precision medicine where we don't make a move in cancer without precision medicine. Why should we think otherwise in COVID and long COVID, and use ridiculous markers like CRP and SED rate and D-dimer, which are 3 of the most inaccurate tests in my clinical pathology career I've ever seen, and not look at what is really going on. So people were surprised when we identified cytokines in these abnormalities. Now everyone's talking about cytokines and abnormalities in long COVID. I even talked to the head of the NIH who said 2 years ago, oh, there's no cytokine involvement in these patients who have symptoms long after COVID. I said, excuse me, Dr. So-and-so, here's our paper. There is indeed a cytokine profile. They just don't happen to be common cytokines. So you're not going to be able to order RANTES or CCL5, in your hospital lab. So that's why we made a kit. We got it out to reference labs in the United States, and we got it out to reference labs in Europe. And now, it's got all the appropriate approvals.
Thank you for that. I appreciate that. I will now be asking questions from the audience. If Dr. Islam, you could comment on, you had talked about there is differences with long COVID that we're seeing in terms of gender and in terms of age. Would you have any thing to say about any differences in terms of geography or prior health conditions?
Well, I would say that prior health conditions is, been pretty normal. Most of these patients have been fairly healthy prior to their experience with long COVID. Now, certainly whether a history of prior EBV or Lyme, these are not usually typically reported in the studies that have, the epidemiologic studies that have reported on long COVID. The patients tend to be, younger, female. Obesity is a risk factor for everything acute and post-COVID. So whether those are having some kind of interplay, we know that, women, their biology is different. There's increased autoimmune conditions that occur in women, whether it's Sjogren's, lupus, rheumatoid arthritis. So the epidemiology of women being affected more with long COVID could suggest there's an autoimmune feature here, or whether the biology CD4, CD8 is different based on the gender differences in our immune system. That could be at play as well. With respect to geography, I don't think so. I don't think there is a geographic difference that I've seen reported. It's been pretty similar no matter what institutions reporting I've seen.
Another factor, though, is during the menstrual cycle, women with long COVID tend to get worse. So, in many cases, if it's okay with them and their primary care physicians, they go on oral contraceptives, it smooths out their long COVID throughout the month, and they tend to improve. So that's something to really take into consideration is the exacerbation during the menstrual cycle.
That's incredibly interesting. Thank you. This is a question specifically for you, Dr. Patterson. It's actually going to be a 2-part question. Someone said that they missed the 2 therapeutic agents that you had mentioned, and if you could please repeat them.
One is Maraviroc or Cellzentry. It's a CCR5 antagonist, and it blocks the CCR5 receptor on immune cells. And that was the receptor by which HIV gained entry into T cells. So people mistakenly think that it's an antiviral because it's used in HIV, but it's an entry blocker, okay? The other misconception is that it's an immunosuppressant. It is not. It is an immune modulator, which we showed in our first study actually increased CD8 count. It relieved T cell exhaustion, and it increased the expression of granzyme A, which are the magic bullets in CD8 T cells, which kill virally infected cells and tumor cells. So it is a great immune modulator and enhancer. And it's not an antiviral. But the fact is CCL5, CCR5 is one of the major pathways in moving immune cells to areas of inflammation. And there are times that we don't want that to happen. And the other thing that mobilizes these cells carrying S1 is exercise. So during our 6 to 12 week treatment course, we say you can walk, stay under 5,000 steps, but do not do resistance exercise, physical therapy. All these other groups are trying to like beat it out of you, and nothing could be worse. And also stress. There's a paper in one of our latest papers that shows that stress mobilizes non-classical and intermediate monocytes. So it's critical to do whatever we can to keep these heavily inflammatory cells from mobilizing around the body, and they go through the blood-brain barrier. So you know what? That's instrumental. That's what Maraviroc does. We can use any statin. We like pravastatin because it's got the least number of side effects. And the last thing we want to do is give somebody with a lot of symptoms, more symptoms. If they can't take statins, we substitute fenofibrate. And we're actually working with a company that had a statin substitute in Michigan. And we may do a clinical study using that drug with Maraviroc.
Excellent. And now here's a question about people with pre-existing ME and whether you have seen them have a worsening of the symptoms or experiencing new symptoms with long COVID.
Well, we don't even know that they have long COVID.
Right.
You know, like I said, because they're so immunosuppressed during acute COVID, it's absolutely a possibility, or if any, maybe even a probability that they're going to get reactivation of herpes or EBV or what have you. And our goal there is let's treat the source. So we'll treat the bug, you know, with Valtrex, for instance, with Maraviroc and pravastatin. So we treat the bug and we treat the immune system at the same time in the MEs. And that's been very, very effective. And we're also developing a new test. It should be launched in a month or two to do for EBV reactivation on a molecular basis. The serology is terrible. IgM for, you know, to say something is active with chronic infections is absolutely terrible. So we, when I was at Stanford, I developed an assay that did RNA to DNA ratios. EBV and the chronic herpes viruses are all DNA viruses. So you use that as the denominator, and then you look at RNA copies as the numerator, and you can actually see where there's molecular reactivation. And I think that is absolutely critical as we go forward with now a renewed acknowledgement of ME/CFS, and also long COVID, and trying to separate those as we devise treatment strategies in clinical trials.
Thank you very much. That is it for our session. I want to thank both Drs. Islam and Dr. Patterson very much for their time and for their presentation today, and I look forward to talking to them later. So thank you very much.
Thank you.